And with that, I'd like to welcome our moderator for our first session. I think we're right on time now. We'll welcome to the chat Eric Harris. He is Associate Executive Director of External Affairs for Disability Rights California, and he'll be kicking us off with the first session on advocacy and policy.
Fantastic. Thank you so much, Ken, and thank you all for having me. My name is Eric Harris. I use he, him pronouns, and I am a dark-skinned Black man with a beard and mustache. I have dark-rimmed glasses, and I'm wearing a blue polo shirt, and I have the background of Disability Rights California's mental health awareness on my Zoom. Um, and I'd like to begin by introducing our first speaker, Laurel Maury, who will be presenting Getting State Legislation Proposed is Easier Than You Think. And so I will go ahead and pass it over to Laurel.
Hi, my name is Laurel Maury. I am a middle-aged white woman with long, slightly frizzy hair, chocolate-covered t-shirt. My background is my bookshelves. They're slightly messy. I'm very pale, and I'm wearing glasses, blue rims. I am not a clinician. I'm not a medical person. I'm an engineer. SMATI let me come because I was fighting to get my degree at Hopkins because they're rather terrible towards me and towards disabled people in general. And we tried. I I am hard of hearing. I have ADHD and I have primary immune deficiency, which some of you might know what it is, but some of you won't. Basically, if you have a cold, I have a bad cold or bronchitis or pneumonia. I in 2021, I was about to be, I failed 2 courses at Hopkins because I got pneumonia and I didn't withdraw. I was not thinking about that at the time. And they decided to kick me out, probably in retaliation for taking a professor to equity, to a civil rights complaint for requesting my medical records to see if I really deserved an extension. Some of those medical records were gynecological. I fought that and won, and I think that's why they were trying to throw me out. As I was being possibly dismissed, I wrote an article for the student paper. I wanted to warn other disabled students what it was like. I fought the dismissal off, which is very rare for disabled students once you've been sort of pinged as a troublemaker. And the Hopkins held an assembly about my article and didn't invite me. I found out about it on social media. But the newspaper put me in touch with 5 disabled counseling students who had been kicked out of their program. And I listened to their stories, and they were all extraordinarily spurious. So we started doing different things. I had fairly recently, I was working on what was going to become the Child Victims Act of 2023 of Maryland because I had been to a K school with a lot of abuse. So I was already talking to legislators. So I started doing the let's talk to legislators part. And it's actually pretty easy. You call them up. You need to do a little research. You need to know who your constituents are, and if you're in a school, and I'm going to talk about this, what it's like within a school, but it's probably similar if you're in any sort of employment. Disabled people, we often have to fight the systems that we're within that we need to survive, and it can be dangerous. And I actually do mean dangerous. Hopkins quite regularly puts disabled students in situations where they are in physical danger. I can share my stories. I was forced to choose between an operation I needed to rule out cancer and my coursework, and I ended up choosing my coursework. Thankfully, I finally had the operation. I didn't have cancer. I was forced to choose between treatment for pneumonia, which can kill me. Let's be clear. I'm not one of those people you can just give antibiotics to and she's going to get better on pneumonia. No, that's not me. It'll take 5 weeks, probably minimum. And I chose to get well. And then later on, they tried to make me delay an immunoglobulin infusion, which really upset me. I'm now pretty stable on human immunoglobulin. So I started going to legislators, and literally you just call them up, you treat them politely, and they will get back to you. You need to know who your two types of legislators you can talk to. Your representatives for your area, which is your physical area, where you are in school, or people who are interested in, say, disability, or in my case, is disability and education. We quickly found a delegate called Delegate Guyton who was interested in disability and education. My local delegates were not that interested. And what I found out was the delegates want to talk to real people. They do not, they talk to lobbyists all the time. So, and there are two types of conversations you can have with an elected official, and you have to have one or the other in any given conversation. First one is constituency services. Constituency services means they are going to reach out to your institution, your employer, your situation on your behalf. And they have some powers to compel places to answer, particularly those places are getting tax dollars, which even private institutions are. So they asked Hopkins about stuff, and they found out that they really didn't have much power over Hopkins. Hopkins could say no or not answer questions, which they really weren't supposed to do, but the legislators had very little power. And Senator Maury Washington actually assigned a staffer to help try to get the disabled counseling students reinstated. To everyone's surprise, she was completely unsuccessful. She is a powerful local senator. She is the state senator for Homewood campus for Johns Hopkins and knows the president. She got nowhere. Then we started talking about legislation. And legislation is a mix of what is needed and what is possible. And a lot of what I'm telling you now is what staffers told me, because we aren't lobbyists. We were mostly science students, a lot of engineers, a lot of people in actually health sciences, because those were the people the counseling students knew. And so, you know, some pretty smart people. And I started reaching out to other colleges because any laws we enacted would not have any power over Hopkins. And I found similar stories at UMBC, at University of Maryland, actually at UCLA in California, UVA, the Georgetown people actually wrote an article about this. A great way to find out a lot of what's going on is actually in student newspapers, because they sometimes write about it, and they often do very good reporting. The counseling students pursued an article in the Baltimore Sun, which Hopkins, after a journalist worked on it for almost 2 years, successfully killed, and the journalist got fired. Suddenly, the article was supposed to run. Hopkins threatened to sue. 8 months later, we still heard it was supposed to run, and then the next month, suddenly the journalist disappeared. This also happened to one of our cohort from the University of Virginia with local papers. They seem to have, colleges and universities seem to have a playbook. But they don't have power over legislators and what legislators do. And when we speak with legislators, those conversations are confidential by law in Maryland. I don't know what it's like in California. And the legislators started talking about, and we were talking about legislative solutions. And I say it's a mix of possible. There are two things that you want in legislation. One, you have to, if you can show that it has been proposed elsewhere, it doesn't have to have passed. If it's been proposed elsewhere, or it's in law elsewhere in another state, then you have some basis for it. And it doesn't have to be exact. It can be kind of loose. One of the things we've ended up asking for is that 30% of core courses spend 10 to 15% of their time talking about something related to disability, based on a law in Florida saying that disability has to be included in pre-K through 12 education. And I was saying, in all my time at Hopkins, they never mentioned disability except to say that people with autism tend to be more likely to become malevolent hackers, which I took extreme exception to. So you just call them up, and I'd say if you call up 7 politicians, I think we probably ended up contacting about 15. About 7 were interested. Now, we were doing our research, and we had a lot of smart people. Hopkins students, probably like Stanford students, are smart. So we also had people file. So I'll tell you some other things that don't work. Going to small disability groups, they don't work. They are, and suddenly someone who was actually Biden's disability czar for a year clued me in on why. She said they're all fighting for the same funding. And to get funding, they have to show that they're trying to do federal work. Getting federal law is 20 in civil rights is 20 years of work. That's about how long the ADA took to pass since the first things in the early since the first protests in the early 70s, which the Black Panthers helped us with. And but getting state laws passed is a 3 to 5 year job. So anyway, they won't help. They will talk with you, but they won't share contacts generally. And if you do let them in your meeting with legislators, they will try to hijack the meeting. So we stopped going to them. Apologies about disability rights, Maryland. They were not helpful. I actually went, many of us tried to contact them. Finally, drove up to the offices in Baltimore and started leaving notes. And finally, they called me back and said, sorry, we're not interested. I'm like, we've got legislators. We're talking to them. They're talking about getting us a law. And they're like, it's like, luckily, we had engineers in our group. So putting up a website, I'm not paying me. I can do it for, I think I was doing it for like $12.50 a month. Other things that don't work is going through the schools. Any initiatives they put forward, even if they're good, they can take away. So Office of the Civil Rights Offices and Offices of Institutional Equity at Hopkins, at least, if you could do file a complaint there, you are very likely to get kicked out. I'm sorry, but I think of the 10 core group, like, I'm sorry, I'm crying. 6 of us were kicked out. This was a counseling student, another person in the business school. I don't know that she's kicked out, but she just disappeared. Now, granted, many other people in our group have health problems. Some are severe. Okay, but I'm going to the take-home points are this. Do your research. You need to find your way around a tool called Legiscan, which is going to help you find similar laws. AI has actually been great for that. You need legislation. You need something called a two-pager, which staffers will help you write. And that is your calling card for your legislation. And you probably need a couple tries. We had a try, HB 912 would have required all professors in Maryland State schools to undergo ADA training, which we got from a law in New York, actually proposed legislation in New York. But the final thing I want to leave you with is when you're asking for stuff as a disabled person from employers, from disability groups, from schools, you are pleading, you are often burning down your dignity. When you walk into a legislator's office or Zoom with a legislator, you are participating in a democratic process that is built for this kind of conversation. You are having a conversation that could make your society better. You are not burning down your dignity. If anything, you are increasing it. You are not pleading. You are a citizen exercising your rights. It's empowering and it's good. It's not, that pleading voice that I often hear disabled people use when they ask for something, it starts to go away because you're being heard and they have tools. And the final tool, legislation, is really difficult to undo if they put it in place. That's what I want to leave you with. If people have questions, talks, like I said, I'm not a lobbyist. I'm a back-end engineer, and I can make this work. So you guys can too.
This is Eric. Thank you so much, Miss Maury. We really appreciate your story and really appreciate the information that you shared with the group. And I know that we'll have some questions for you a little bit later. Once again, this is Eric speaking, and I'm going to introduce our next panelist. His name is Amged Soliman, and he is a senior attorney and advisor at the National Council on Disability, an independent federal agency. He is a member of the Maryland State Bar. His work at the National Council on Disability has involved serving as the staff lead of NCD's health disparities initiatives, including related issues of improved medical and dental school disability clinical care and competence training, as well as Medicaid coverage and data collection. So I will go ahead and pass it over to you.
Thank you. Good morning, everyone. My name is Amged Soliman. As Eric just mentioned, I am a middle-aged Caucasian man with short black hair, glasses, and a blue suit. I'm happy to join you all today. This is an important issue, one that must be addressed. So I really appreciate the opportunity to share some thoughts. As Eric mentioned, I do work for the National Council on Disability, an independent federal agency. But just to give you a little bit more specifics, our job is to provide recommendations to the White House, Congress, and other federal agencies on issues of disability policy and law. And we have been focused like a laser beam on issues of health disparities and more specifically, clinical disability training of medical professionals, and before that, dental professionals. I do have some slides here that I'm going to share. And the team at Stanford did a good job of teaching me how to do this, but hopefully I'm going to do a good job of honoring what they taught me. Let's see. Okay. Did that work? I'm sorry, did that work?
Looks good.
Yes.
Okay, good. Thank you so much. Okay. So today's topic title for my presentation is Disability Clinical Care and Competency Training and NCD Update. So I have nothing to disclose. So obviously, the people who are with us today know the importance of this issue. In addressing it, we try to look at how the problem can be solved, right? Not just medically, but also in terms of policy to help make the realities on the ground possible for improvement. NCD had put together a framework a few years ago, and it was called the Framework to End the Health Disparities of People with Disabilities. And one of the main components was related to the issue of disability, clinical care, and competency training. So what's the update? In short, I would say that while there has been growing consensus on the importance of this issue, a consistently applied national standard remains elusive. I'd like to talk a little bit more about our component number 3 of our framework, the one related to disability, clinical care, and competency training of medical professionals, because it is important to sort of delve into what the related problems are. So as most of you know, most providers report that they have had little to no training and exposure concerning disability, clinical care, and competency training. Oh, I'm sorry. Here we are. Now, things have developed differently of late on the oral health side. But as we've seen through the pandemic on the medical side, there's problems on both sides. But as we've seen during the pandemic, this issue was highlighted in the triage protocols that were used and the quality of life assessments that doctors had. It was very evident that most providers have not had any disability clinical care or competency training. Also, one's apparent disability, even when unrelated to the reason for their healthcare visit, can result in diagnostic overshadowing the clinical concern and can have a negative impact during the healthcare visit. This lack of familiarity and understanding of disability is detrimental for quality of care, contributing to delays in diagnosis and treatment and unsafe care. Also, due to the lack of familiarity, people with disabilities are sometimes viewed as asexual. This assumption contributes to the finding that women with disabilities undergo colon cancer screening at a rate that's not on par with their non-disabled peers. They experience disparities in cervical cancer screening, and the sexuality. Sorry, I'm not able to see. There we go. The sexual health of women with intellectual disabilities is particularly ignored in terms of screening for breast and cervical cancer. While, as this audience knows, there are several medical schools in the U.S. that already serve as leaders in this space. Most do not. So what is NCD's recommendation? NCD's recommendation is that standard comprehensive disability clinical care education and training of medical, nursing, and other healthcare professionals is essential for a better educated healthcare workforce trained with an understanding of disability as a natural part of the human condition versus conditions that must be avoided, prevented, or fixed. Comprehensive disability clinical care competency should be woven into the curricular requirements of all U.S. undergraduate medical, nursing, healthcare professional, and allied health professional education, as well as postgraduate residency and fellowship programs that are conducted in over 1,100 teaching hospitals. So I wanted to talk a little bit of what the core competencies that NCD is recommending should be taught when it comes to disability clinical care and competency training of medical professionals. The first is a contextual and conceptual frameworks on disability. The second is professionalism and patient-centered care. The third is legal obligations and responsibilities for caring for patients with disabilities. The fourth is team and systems-based practice. 5, clinical assessment. The 6 is clinical care over the lifespan and during transitions. And this one, they're all important, but this one is important because, as we all know, children oftentimes get better care in this space. That their providers are better trained in this space. But what happens when children are no longer children? The 7th is effective communication, and the 8th is advocacy of the patient. Now, as I mentioned before, NCD has been focused on this issue for some time, and I'll talk about it a little bit more later, but I can say that there have been some successes on the oral healthcare side, but the medical side has proven to be more tricky, as everyone here knows. So in addressing this issue, we approached the institutions that have a say in this matter. And I thought I would just share a little bit or give an update as per the title of this presentation concerning where things stand currently. The LCME, the Liaison Committee on Medical Education, they are the ones responsible for setting the standards of what medical schools have to teach and not teach. We approached them concerning this issue, and their response in short was to say that they're leaving it up to the schools. Obviously, there are disability rights laws that have to be complied with, and their statement was that each school is responsible for making sure that they are in compliance with federal law. That was their response. And there's the Joint Commission. The Joint Commission has been very good about saying that this is important, there is a need for this, but they stop short of sort of getting behind a specific national standard. And that's what we've seen a lot of. This sort of quote, this is needed, however, schools should do this out of their own volition, doctors should be, pursuing this out of their own volition. And we also approached the ACGME. They deal in training post medical school, and it was the same approach. We vehemently believe in this. We completely agree that this is important, but they're stopping short of a national standard, a national requirement beyond the arguments of the ones that already exist. Now, that's not to say that they're not being genuine when they say that they believe in this. I believe they are. And to that point, they have sponsored national conferences talking about the importance of this issue. They've gathered together people who run these programs and residencies programs and medical school programs to talk about the importance of this issue. But as for a more specific national standard, they have stopped short of calling for a need for that. And then there's the state and federal components. Currently, there's no very specific federal standard, though NCD is of the position that disability clinical care and competency training is consistent with Section 504 of the Rehabilitation Act of 1973, which prohibits discrimination on the basis of disability in programs and activities receiving federal financial assistance. It requires recipients, such as public schools and hospitals, to provide equal access and reasonable accommodations. And the Americans with Disabilities Act requirements essentially do the same. Again, except with respect to private actors. Again, the LCME has noted their position that medical schools are responsible for their own compliance with federal laws. Certainly, you're not providing, or how should we put this? Are you providing equal access when the patient before you can't be treated because you didn't train the medical providers to give them or understand their situation, right? That's the issue, of course. And I think states would be wise to develop more specific law or policy concerning disability clinical care and competency training in the absence of more specific standard at the federal level. Now, we've seen some of this. Massachusetts, I believe, passed a law. I'm not sure if it's required of all schools or it sort of gives the option to schools to develop this kind of training. But the more we see of such laws, especially if it's sort of very specific about what needs to be done and what's required to provide the care that patients with disabilities need and should have, it's important to remember that the more specifics, the better. But I mean, we don't want to be too pessimistic. There have been situations that are encouraging. As I mentioned before, we have done some work on the oral healthcare side of this equation, and it might help people to know of some of those successes. And I want to share with you a story about a little girl who needed dental care. And it used to be the case that the American Dental Association Code of Professional Conduct said that you cannot turn away a patient based on their race, their nationality, but it did not say you cannot turn away a patient based on their disability. Well, we worked with the American Dental Association to change that code of conduct. It now states that you cannot turn away a patient based solely on their disability. And if you're unable to provide care, you have to refer them to a provider that can give them care. And a lot of states adopt the code as written by the American Dental Association into their own state laws of professional responsibility. And there was this little girl who could not get a dental appointment. She could not find a provider willing or able to treat her. Her mother was very frustrated. The New York Times did a story about this. And months and months and months would go by, and she couldn't get the care she needed. She couldn't get an appointment. Oftentimes, patients would have to travel, very far away to other states to find providers who can care for them. And she finally found a provider who would give her an appointment. The appointment was 6 months out, but her mother said, "That's okay. I'm just glad I found an appointment." 6 months go by, and I think the night before the appointment, they got a call from the provider saying that the appointment was being canceled. And of course, mom was in tears. And the person on the other end of the phone line, to their credit, said, "Okay, hold on, let me see if there's anything I can do to help you." And she looked up the Code of Professional Responsibility that the ADA had just put out. And they found that it says you can't turn away a patient based on their disability. And if you're unable to provide care, you have to refer that patient to a provider that can treat them, which is what happened. And the next day, you'll see what happened the next day. But I would just mention that, the name of the article in the New York Times was saving the teeth of patients with special needs. It was in May 2019. So a positive difference can happen, because the next day we saw that Bella got the treatment that she needed. And this is a picture of Bella, a little girl with black hair in a chair, all smiles, surrounded by the professionals that were able to treat her. So things can get better if you put the right policies in place. And as I mentioned before, finding a very specific national standard on the medical side of this equation has remained elusive. But there is an argument to be made that people should seek this training in compliance with 504 and other federal laws. And more and more medical schools are doing this. But I think a lot of people dream of a time when all medical schools and residency programs are doing this. So with
Great.
that, I would wonder if there's any questions,
Great.
and I'm happy to answer any that if there are.
Thank you so much, Amged. I really appreciate your presentation and all the work that you do. We're gonna move into Q&A now, and I have a few questions that I can kind of get started with. So first for Laurel, I know you talked a little bit about what you would recommend for folks as they kind of get started with policy advocacy or legislative advocacy. Um, so if you can expand a little bit on that, but also if you want to talk a little bit about uh, what motivated you specifically as a disabled person to get involved in legislative advocacy, because as you said, there are other organizations that do legislative advocacy. Disability Rights Maryland does disability rights advocacy. Um, and you know, you
Not
talked
at the
about some of the
college,
issues
not at
there,
the
but
not
yeah.
at the college, not at the college level. They don't.
Yeah.
A couple of things. First, how do you get started? I'm going to give you a crazy thing. Go to a fundraiser, go to a benefit. You don't need a $250 ticket. Yesterday morning, I went to a Democratic breakfast. I paid $5, and for that $5, I got to speak. There were 7 candidates there, 3 of whom were for something. Now, candidates are good to speak to because they know people. Even if you're speaking to not the politician you want, they know people. Give them your elevator pitch, write down your email. The thing that you really want to see is if you talk with them and they go away and then they gesture their staffer to come talk to you, that means you're in. You do not cling to the politician, the staffer. You talk to the staffer, and the staffer will take your information. I paid $50 to go a couple years ago to a benefit at the Annapolis Maritime Museum, sitting there and eating oysters. I got probably some of my husband's beer on my shirt. I got to speak to Ben Cardin because I knew Sarah Alfrith, because from this breakfast, I went over, she pointed me to Ben Cardin. I gave her a pitch. He said he went like this, and then pushed it, and then someone pushed me, one other staffer pushed me to the other staffer. And a couple of weeks later, we had a half hour with his staff, me and the
Mm,
groups. Go to these things. Get the hell out of your colleges and universities. They're very fishbowly. You Local politics is full of people who want to help. And even if you don't speak to a politician, the community organizers are going to know who you're going to talk to.
mm,
They all, that's one thing. Why did I get started? I'm 55 years old. I was hearing from disabled students who are undergraduates having a worse time than I did when I started college before the ADA began. It was hard then, but they weren't doing things to threaten their people's lives. People with, you know, it's, I can't really go into details beyond telling other people's stories, but um, it's dangerous, and you will have to choose between treatment and your academics at some point, and that could be in
mm,
a situation that can kill you, and they do not care. And I'm a tough person, but to see 17-year-old, very bright, hardworking kids, they're kids, they think they're adults, but sorry, anyone under the age of 25 is a kid. I would come away from these things and I would cry. And okay, fine, come at me. I was already lawyered up with the lawyer who was meaner than I was. But don't go after kids. I'm sorry. That's
mm.
why I did it.
Yeah. Well, I really appreciate that response. And for the interest of time, Amjad, I have a question. It's hopefully going to cover a couple of different things, but bear with me a little bit. So the National Council on Disability, current priorities, if you can talk a little bit about current priorities. There's so much going on at the federal level, all throughout the country. Disabled people, our rights are being stripped away in so many different ways. So if you could talk a little bit about that, and then also how can healthcare institutions better align with NCD's recommendations on disability inclusion?
Sure. So NCD's been around for decades, and we work in pretty much any space that deals with people with disabilities: employment, healthcare, housing, you name it, we try to pay attention to it. I would say with respect to healthcare, which is the reason we're here today, for sure, NCD's priority at present is the issue of disability clinical care and competency training. We are in the process of developing a policy brief that speaks specifically to this issue. And in terms of what hospitals can do to sort of make an improvement, I would recommend that they take a look at our framework posted online at ncd.gov, framework to end health disparities of people with disabilities, specifically the section related to disability clinical care and competency training. Take a look at our 8 core competencies. And we believe that every medical school should develop, if they don't already have one, curricula training program for their students to learn how to care for people with disabilities. Likewise, the heads of residency programs, if you're not already training your residents on how to treat people with disabilities, then you're doing them a disservice, because, I mean, it just comes down to the fact that, are you trained to treat the patient in front of you or not? And if you're not getting this training in medical school and you're not getting it at residency, then how can you treat the patient in front of you, right? That's what it comes down to. So I think people should start with just knowing that this is something that has to be done.
Justice Eric, I really appreciate that from both of you, and you both are wonderful panelists. Thank you for your vulnerability, especially you, Laurel. Really appreciate your story and all of the work that both of you have done. And now I'll go ahead and pass it over to Ken.
Great. Thank you so much. Thank you for that outstanding session.